Hello, my name is Josephine Aruvie. I'm a Doctor of Nursing Practice student at Maryville University. I will be presenting my Doctor of Nursing Practice scholarly project on the topic Use of Diabetes Self-Care Behavior Model to Improve Patient Outcomes. Before I proceed with my presentation, I would like to acknowledge my Maryville University committee members. Dr. Rita Wonderlich. Dr. Wonderlich is my chair. She has been very supportive throughout my program and throughout my project. Dr. Maria Snare, who is the Dean of DNP program, she has been very supportive. Dr. Adebisi Alinsin is my community mentor. She has also been supportive. In addition, I would like to acknowledge Dr. Jean Gordon. Dr. Jean Gordon was supportive during the initial part of my project. Dr. Okwesomi, who is the medical director and the provider at my project practice site. Ms. Laura Kagerman is my student advisor. She has been very supportive throughout my program. Thank you, everyone. My population of interest is patients with type 2 diabetes. Type 2 diabetes mellitus is a global epidemic disease. Over 462 million people worldwide have type 2 diabetes, and over 95% of people with diabetes in the US have type 2 diabetes. Type 2 diabetes is a very complex disease to manage, both for the patient and for the healthcare professionals. Background and significance. According to ADA, according to American Diabetes Association, patients do not meet glycemic target of hemoglobin A1C of less than 7%. Poor self-care knowledge among this population is a major cause of poor glycemic control. Providers at primary care clinic are usually not consistent with the use of the ADA's self-care management practice guidelines. As a result, patients with type 2 diabetes experience serious diabetes complications such as kidney diseases, cardiovascular diseases, gangrenous foot, and so on. Patients with type 2 diabetes have a shorter life expectancy rate compared to their counterparts without type 2 diabetes. Type of inquiry. This project was a quality improvement project, and it was meant for change in practice. The purpose of this project was to determine if consistent use of the diabetes care and education specialist, which is the ADCS-7 self-care behavior model, improves glycemic control among patients with type 2 diabetes. The aims was to implement consistent use of the ADA's self-care management practice guidelines and examine the effect of the diabetes self-care education program on glycemic control. The pickled question that guided this project was, will the consistent use of the Association of Diabetes Care and Education Specialists self-care behavior model during clinic visit improve blood glucose in 3 months as compared to pre-intervention baseline measures? Several articles were reviewed during this project. However, 15 primary articles were used for integrated literature review. And the literature review were classified into 4 different themes. First one was poor health literacy, which is a major problem among patients with type 2 diabetes, they lack knowledge of, majority of them lack knowledge of self-care, how to manage their disease. Diabetes education is a major component and a major intervention to reduce poor literacy or to improve patients' knowledge and awareness of how to manage type 2 diabetes. Number 3 is glycemic control, which is the target and the goal of intervention. Integrated healthcare is another component of care that this population can benefit from. The theoretical framework that supported this project was the trans-theoretical model of change. Trans-theoretical model of change is classified into 6 stages, which really applies to, this model really applies to this population as in relating to their level of readiness to adopt self-care behaviors. The trans-theoretical model of change, as I said, is classified into 6 stages. The first stage is the pre-contemplation stage, where the patient or where that patient with type 2 diabetes has, or a patient with type 2 diabetes has poor knowledge of self-care, poor knowledge of their health or of their illness, and they're not ready to engage in any self-care behavior even in 6 months from now. The second stage is the contemplation stage, when the patient intends to engage in self-care behavior in another 6 months to come. The third stage is the preparation stage, when the patient is really ready for action, at least in the nearest future, like a month from now. The action stage, which is number 4 stage, is when the patient is engaged in self-care behavior, actively engaged in self-care behavior such as physical exercise, eating healthy foods such as fruits and vegetables, drinking plenty of water, maintaining, keeping doctor's appointments, monitoring blood sugar, staying healthy, and so forth. Maintenance stage is number 5 stage, when the patient is already sustaining their health, maintaining healthy lifestyle. They're in full action and maintaining health. And the termination stage is a stage where the patient is not ready to go back to their pre-contemplation stage or relapse. And in some cases, patients can relapse at this time and go back to the pre-contemplation stage when they give up on healthy lifestyles. However, patients can be at any stage. It does not have to be in sequence. They can be at any stage. A patient can start with contemplation stage. They don't have to start with pre-contemplation. However, these are the stages of trans-theoretical model that supports the care of type 2 diabetes, and they are related to their readiness to adopt self-care behavior. The methodology for this study. The study was a quantitative study using retrospective chart review of pre- and post-intervention data, which the data were hemoglobin A1C and BMI. The setting was primary care clinic. Sample selection was through convenient sample, only the patients available and who met the inclusion and exclusion criteria. The size of that sample was 22. Age of the patient participants were 18 and older. The population were patients with type 2 with diagnosis of type 2 diabetes. Inclusion and exclusion criteria were used. The inclusion criteria included, as indicated, 18 years plus, type 2 diabetes diagnosis, patients who could speak English, patients who were seen and received type 2 diabetes education, self-care education between September 30th and October 14, 2022. Patients who received treatment for type 2 diabetes within 6 months prior to the intervention, and patients who completed the pre and post intervention hemoglobin A1C labs and BMI follow-up. The exclusion criteria: any patient who did not meet the inclusion criteria, patients with gestational diabetes, patients with type 1 diabetes mellitus, and patients over 90 years did not meet the inclusion criteria. The budget for this project was only $177.42, which was mainly spent on printing this ADCS-7 self-care module transcript and transportation to and fro to the practice site, to collaborate during planning stage, and to collect data post-intervention. The timeline for this project, active timeline, was between May 2022 till this period. Between May and September 2022 was the planning stage, and during that stage as well was the application for Meriview IRB approval, and the intervention was launched on September 30th and completed on October 14th. Data collection occurred on January 14th, completed on January 14th. Data analysis was completed between January and March 2023, and presentation is going on now. The intervention, as earlier stated, is it was type 2 diabetes education using the ADCS-7 self-care behavior model by the practice provider. Method of evaluation: data collection instruments were the hemoglobin A1C, as earlier stated, body mass index, which were the pre and post intervention hemoglobin A1C and BMI values in ranges. Ethical consideration was maintained throughout this project. IRB approval was received before embarking on data collection. Patient confidentiality was maintained. There were no patient identifiers used in the data collection. Minimum data were collected. No biographic data used in this project. Data analysis was completed using the IBM statistical package of social science, which is the SPSS software. Wilcoxon signed rank test was used to analyze the data. The outcome of the data: there was no statistical significance between the pre and post intervention outcomes. There was no significant difference in hemoglobin A1C and BMI pre and post. The p-value for this project outcome was 0.317, which is higher than 0.05. The result: the pre and post intervention hemoglobin A1C result. Looking at the graph, 21 out of 22 patients maintain the same range of pre and post intervention hemoglobin A1 levels, while only one patient, who was patient with chart number 17, was actually an outlier, and post-intervention hemoglobin A1C was higher than even pre-intervention. That was a surprise. I thought there will be reduction in hemoglobin A1C result, but in this case, there was none. The patient's hemoglobin A1C actually went up higher. Similarly, in the BMI result, one patient who was patient number with chart number 7 had increased post-intervention BMI result, while one patient with chart number 18 had a reduction of BMI post-intervention, which was a positive outcome. However, it was only one patient that was identified to have a positive effect. Discussion: there was no evidence of improvement in outcome result. There was no significant evidence in outcome result. There was no significant improvement too in self-care behavior, and there was no evidence of improvement in lifestyle modification. 95% of the participants maintained the same hemoglobin A1C and BMI range. Previous studies showed improvement in glycemic control, even though this study did not show significant improvement. However, previous study based on literature review showed improvement in glycemic control post-diabetes, post-self-care diabetes education. The strength of this project, I would say no missing data. There was no missing data. All variables were analyzed. Ethic consideration was maintained. No personal relationship with the project site. The limitations for this project were small sample size, limited time frame. There no interaction with the participant. If there were interaction, maybe it could have been a different result. No randomization, it was only convenient sample used. No demographic data collection, no co-founding data collection. If this were known, probably it could have been a different outcome. Barriers, as indicated, there was inability to use confounding variables. Demographics were not used. Other comorbid diseases such as cardiovascular diseases were not used. Facilitator, there was a significant support from the practice site staff and the provider. Accurate documentation of hemoglobin A1C were retrieved directly from the lab by the provider into the participant's EMR system. The staff at the project site took and completed documentation of the participant's weight and height, which generated the BMI result. Implications of these projects on healthcare practice. This project set standard for the practice to improve. For improvement in practice, patients were able to learn from this project. They had opportunity for learn. This project increased patients' compliance to treatment, and if they are persistent, this can result in sustainability. Implications on healthcare policy. I would recommend that there should be enforcement of new law to mandate the use of the ADA self-care education practice guidelines in the primary care. This project has created opportunity for research in related topic, which is the type 2 diabetes. I will suggest randomization and a larger sample size for a future research. Conclusion: based on the outcome result, there was no statistical difference in the pre and post intervention outcome. And the positive contributing factors to this could be small sample size, short study time, and method of reporting study variables too, of reporting the hemoglobin A1C and the BMI, which they were reported in range instead of actual values. Evidence: past studies have shown that ADA practice guidelines of type 2 diabetes self-care behavior education can improve glycemic control among patients with type 2 diabetes. Sustainability: a model, this project serves as a model for type 2 diabetes self-care education in the primary care clinic. It sets a standard to follow the ADA practice guidelines, and the provider is to continue the same protocol and evaluate a long-term effect, such as in another 6 months or 1 year. The reference to this project can be found on the link below, that is via Google Doc. And I'm very open to all questions related to this topic. I can be reached at jaruvie1@life.maryville.edu. And thank you so much for listening.